Today we will be watching a race between hypothyroidism, or Hashimoto the tortoise, and hyperthyroidism, or Graves the hare. But first, we're going to talk about how the thyroid functions normally. Hello, today I'll be discussing the thyroid. Here's a diagram of where it is located. The thyroid is a normally small gland located at the front of the neck. Its principal function is to convert iodine into thyroid hormones known as T3 and T4. These hormones are distributed into the bloodstream where they regulate metabolism. The pituitary gland plays a big part in thyroid function as well. When the levels of T3 and T4 drop too low, the pituitary gland releases thyroid-stimulating hormone, which stimulates the thyroid to produce more T3 and T4. And now for hyperthyroidism. Hyperthyroidism is a hyperactivity of the thyroid gland which causes an increase in the release and synthesis of thyroid hormones. While there are several causes, Graves' disease is the most common form. Graves' disease is an autoimmune disease where the body produces antibodies to the TSH, or thyroid-stimulating hormone, receptor. These antibodies cause an excessive release of T3, T4, or both. This excessive release of hormones leads to the thyroid enlargement. Some of the other causes include pituitary hormones, thyroid cancer, thyroiditis, and toxic nodular goiter.
Hyperthyroidism can mimic other health problems which can make it difficult for your doctor to diagnose. It can cause a variety of signs and symptoms including sudden weight loss, tachycardia, increased appetite, fatigue, muscle weakness, difficulty sleeping, nervousness, anxiety, and irritability, sweating.
So hot. Oh my god.
Increased sensitivity to heat, skin thinning, and fine and brittle hair.
Alright, if hyperthyroidism is left untreated, some risks or complications that you could face are the development of goiter. Thyroid-stimulating immunoglobulins, or TSIs, are specialized antibodies that trigger the thyroid to release its hormone despite the regulation of the negative feedback loop. This overstimulation of the thyroid gland causes the goiter, congestive heart failure, or CHF, tachycardia, abnormal heartbeat such as AFib, hypertension, increase in the size of the heart cavities and thinning of the heart muscle, and ultimately cardiac arrest. You'll also have exophthalmos, or protrusion of the eyeball. Pretibial myxedema. This type of edema is non-pitting, unlike typical peripheral edema. And finally, the most serious complication if hyperthyroidism is left untreated is thyrotoxic crisis, or STORM, which is a rare but life-threatening condition of hyperthyroidism. Death can occur within 48 hours without treatment. It is also triggered by excessive stress, and it's clinically manifested in tachycardia, hyperthermia, agitation, delirium, and nausea, vomiting, and diarrhea, which could lead to fluid depletion.
Here's some PTU.
Okay, so we also have anti-thyroid drugs, and these are indicated for treatment of hyperthyroidism, such as Graves' disease, and also to prevent surge in thyroid hormones that will occur after surgical treatment or radioactive iodine therapy for hypothyroidism or thyroid cancer. And we have two different types of anti-thyroid drugs. We have propylthyracil, or PTU, and this is dosed at 100 to 150 milligrams a day PO. And then we also have methimazole, or tapazole, and this is dosed at 5 to 15 milligrams a day PO. And these both work by inhibiting the incorporation of iodine molecules into tyrosine, which is needed to make T3 and T4. And this impedes the formation of thyroid hormone. And so some adverse effects we would see would be drowsiness, headache, vertigo, nausea, vomiting, diarrhea, agranulocytosis, thrombocytopenia, decreased urine output, increased BUN and creatinine, and enlarged thyroid gland. And some nursing considerations we want to take into account is that it takes about 2 weeks of therapy before symptoms will improve, so we're going to want to educate our patients about that before And drugs may interact with oral anticoagulants, so we're going to assess for risk of bleeding.
Yay!
And now for hypothyroidism. Hypothyroidism is a decrease in TSH secretion or hypothalamic dysfunction with decreased TRH or thyrotropin releasing hormone secretion that causes a slowing of the metabolic rate. The most common cause of hypothyroidism is a lack of iodine or atrophy of the thyroid gland. Additionally, hypothyroidism can also result from treatment of hyperthyroidism, such as a thyroidectomy or radioactive iodine therapy.
The signs and symptoms of hyperthyroidism vary depending on the severity of the hormone deficiency. But in general, any problem you tend to develop slowly, often over a number of years. At first, you may barely notice the symptoms such as fatigue.
Hey, wake up. Wake up.
And weight gain, or you may simply attribute them to getting older. But as your metabolism continues to slow, you may develop more obvious signs and symptoms. These include fatigue, increased cold sensitivity,
Oh, so cold. Can someone turn on a heater?
constipation, dry skin, weight gain, puffy face, hoarseness, muscle weakness, elevated cholesterol levels, muscle aches, pain and swelling with joints, dysmenorrhea, thinning hair, bradycardia, hypoglycemia, and hypotension.
If hypothyroidism isn't managed properly, some risks that you can come across is goiter due to the constant stimulation of the thyroid to release more hormones. This will cause the thyroid gland to become larger. Heart problems such as heart failure, bradycardia, mental health issues, peripheral neuropathy, infertility, birth defects, non-pitting boggy edema, and loss of mental or physical stamina. The biggest complication for untreated hypothyroidism is mixed edema, which occurs when there's an alteration of the dermis, where the connective tissue is infiltrated with proteins and a sugar complex is saturated in mucus. In addition to changing the person's body image, the oral airway is also inflamed, causing chronic slurred speech and hoarseness. This can lead to myxedema coma, which is an acute medical emergency characterized by severe lack of circulating thyroid hormones.
Yeah, she's not breathing. Let's give her some levothyroxine.
So for treatment, we can give thyroid replacement drugs, and these come in two different options, in natural, such as thyroid or thyroid desiccated, or synthetic. And the main one we give that's synthetic is Synthroid or levothyroxine. And this is indicated for hypothyroidism, prevention of goiter, replacement therapy for surgically removed thyroid, and myxedema coma. And then we have a special black box warning for this drug, and it should not be given for weight loss or treatment of obesity. And then for doses, if it's given for hypothyroidism, we're going to give it PO 25 to 200 micrograms a day, or if it's given IM or IV, we're going to give it 50% of the oral dose. And then for myxedema coma, since it's a lot more life-threatening, we're going to give it through IV, and it's going to be 200 to 500 micrograms once, and then the next day we're going to give 100 to 300 micrograms if it's needed, and this is going to be continued at 75 to 100 micrograms a day until changed to oral dose. And then for the mechanism of action for this drug, it works the same as endogenous thyroid hormones, and such as inducing changes in metabolic rate. And then some adverse effects we would see is tachycardia, palpitations, angina, dysrhythmias, hypertension, insomnia, headaches, anxiety, tremors, nausea, diarrhea. Oh crap! Cramps, menstrual irregularities, weight loss, fever, and heat intolerance, and diaphoresis. And then if we're going to be giving this, we're going to want to make sure to look at the T3, T4, and TSH levels, vital signs, and history prior to administration. And we're not going to want to switch brands during treatment course because this is going to destabilize the treatment. And it has a long half-life, so we're only going to give it once a day. And since it's highly protein-bound, we're going to want to be extra careful with our liver patients and patients who have decreased albumin.